All right, we will go to the prostate cancer part 14. You speak about cryotherapy. The cryotherapy freezing of tissue create a region of coagulative necrosis. Freezing a keeps cell killed by the following methods. Cell rupture occur when the intracellular ice formation generate shear fluid that tear the cell membrane. Cell rupture occur during freezing. Apoptosis genetically regulated cell death or programmed cell death. Apoptosis is stimulated by extreme local conditions that occur after freezing, pH or polarity, and so on. Apoptosis usually occur 6 to 12 hours after freezing. Ischemia freezing induced thrombosis is small vessels. In small vessels, ischemia freezing induced thrombosis, loading or leading to local hypoxia. Cell deaths from ischemia occur 24 to 48 hours after freezing, unlike apoptosis which occur after 6 to 12 hours. Here, ischemia and death from ischemia cell deaths occur 24 to 48 hours. Technique: using transrectal ultrasound guidance and brachytherapy templates, cryoprobe are inserted through the perineum and into the prostate. This is the frozen regions, the ice ball. As you see here, this is the injury zone. Temperature is -40, and this is the necrosis zone. And as you see, edge of the ice, this is the edge of the ice on ultrasound. Temperature here is 0 centigrades, and this is the frozen regions. A catheter-like urethral warming device help to prevent freezing injury to the urethra and reduce a post-operative urethral sloughing. The freezing process is monitored by transrectal ultrasound and by percutaneous thermocouples, needle-like probes that monitor tissue temperature in real time. Ice reflects sound waves, therefore the edge of the ice ball appear as hyperechoic line on ultrasound, and the tissue beyond this line cannot be visualized sonographically. If freezing is started at the posterior prostate, then transrectal ultrasound cannot visualize the unfrozen anterior prostate, thus the prostate is frozen from anterior to posterior to permit optimal visualization of prostate during freezing. Thermocouples are usually placed in the critical structures such as the rectal wall and urinary sphincter. Using thermocouple may prevent freezing injury to this critical structure. Rapid freezing is more destructive than slow freezing. The optimum freezing temperature is unknown, but data suggests that the human cells cannot survive below the -40 centigrade even with slow freezing. To ensure cell death, urologists often freeze to a temperature of -40 centigrade. Two freeze flow cycles are recommended because 2 cycles achieve greater cell destruction than single cycle. Prostate freezing is conducted from anterior to posterior. The temperature at the center of the ice ball is -40 centigrade, which ensures necrosis in this region. Between the necrosis zone and the edge of the ice ball, temperature is -40 to 0, thus the cell might survive albeit injury in this region. Notice that the necrosis zone is smaller than the frozen regions revealed by ultrasound. In order to account for this, the hyperechoic edge of the ice ball is often allowed to extend outside the prostate capsule to ensure the adequate cell kill at the periphery of the prostate. So sperm couples can be placed in the prostate capsule to ensure that this location reach -40 centigrades. Properties of the cryotherapy probe. Know the properties of your probe. In the most cases, the entire prostate is frozen. Partial focal cryotherapy is still considered investigational because long-term data are lacking. Cryotherapy can be performed in minor surgical procedure in which the patient goes home with 24 hours. Patient selection. Poor candidate for cryotherapy. Men who are concerned about maintaining erectile dysfunction occur in most men undergoing complete prostate freezing. Previous to RB, men with previous to RB are at high risk for urethral necrosis and sloughing, especially men who have expensive cavity in the prostatic urethra, a large TURB defect. Men with a large prostate, it is difficult to achieve a uniformly cold temperature during freezing of a large prostate. Before treatment, the prostate size is determined using transrectal ultrasound. Ideally, prostate size should be less than 40 cc. For prostate more than 40 cc, androgen deprivation therapy might be used to reduce the inland size before the cryotherapy. Men with a high risk of regional lymph nodes metastasis, pelvic imaging and or pelvic lymph node dissection should be considered before cryotherapy in men at the risk for N1 disease. High risk localized prostate cancer cryotherapy is not recommended for men with high risk localized prostate cancer. Cryotherapy is probably not effective for palliative treatment of urinary obstruction or bleeding caused by prostate cancer. Men who cannot have transrectal ultrasound probe placement and freezing are guided using transrectal ultrasound. If the patient is unable to undergo transrectal ultrasound, example, anal restriction or no anus from the periabdominal perineal resection, then cryotherapy is contraindicated. So cryotherapy is usually restricted to men with very low or intermediate risk prostate cancer who have not undergone TURB. Cryotherapy may be a reasonable alternative to radical prostatectomy in men with obesity, previous pelvic surgery, or previous pelvic radiation. Cryotherapy may be a reasonable alternative to external beam radiation in men with rectal disorder, inflammatory bowel disease, or who had pelvic radiation. Salvage cryotherapy can be performed after external beam radiation, brachytherapy, cryotherapy. After brachytherapy, this seed and cryoprobe can have a similar ultrasonic appearance in the transfer plane, hyperechoic points, but they can easily be differentiated into sagittal plane. Seed appear as hyperechoic point, and cryoprobe appear as hyperechoic line. Efficacy. The new adjuvant androgen deprivation does not appear to improve the cure rate, but it may be used to shrink the prostate before freezing. Urethral warming prevents freezing of the prostatic urethra and reduce postoperative urethral sloughing. However, it also allows periurethral prostate tissue to survive. This surviving tissue continues to produce PSA, thus the PSA is rarely undetectable after cryotherapy, and it may contain cancer. 35 to 45% of prostate cancer are within 1 millimeter of urethra. Without urethral warming, total cryotherapy has a high risk of bladder outlet obstruction requiring TURB. There is no universally accepted PSA cut point that's defined biochemical recurrence after cryotherapy. Men with PSA less than or equal 0.4 are much less likely to develop biopsy-proven recurrence. Using various definitions of recurrence, disease-free survival is 65% to 95% to 92% in men with low risk or intermediate risk prostate cancer. Local recurrence after chemotherapy tends to occur in the prostate apex. So what side effect of the chemotherapy? Chemotherapy after radiation is more likely to cause side effect than primary chemotherapy. So the side effect usually appear after radiation. So urinary retention caused by prostate swelling or sloughing of the urethral tissue after chemotherapy, and also retention often occur 1 to 2 weeks after and can be managed by anti-inflammatory agent and indwelling catheter. Genital swelling, this is common, but it's usually resolved in 2 to 8 weeks. Benign parathesia, more common after aggressive anterior freezing. It's usually resolved in 2 to 4 months. Erectile dysfunction after chemotherapy. To ensure necrosis at the peripheral prostate, freezing is often extended beyond the prostate capsule. Thus, injury to the neurovascular bundle is common. For whole gland chemotherapy, erectile dysfunction occurs in approximately 80 to 90% of men. Urethral sloughing occurs in less than or equal 15%. Urethral obstruction from sloughing or stenosis. The risk of urinary incontinence is very high when URB or bladder neck resection is performed after chemotherapy. Thus, aggressive resection should be avoided. So the urethral obstruction, that's the urinary incontinence, is very high when URB or bladder neck dissection is performed. Rectal pain occurring up to 12% of men after primary chemotherapy and up to 40% of men after chemotherapy for radiation failure. Urinary incontinence long-term stress incontinence is usually mild and occur in up to 8% of men after primary chemotherapy and up to 22% of men after chemotherapy for radiation failure. Fistula. Fistula, urethrorectal and urethroperitoneous fistula occur in less than 1% of men after primary chemotherapy and up to 10% of men after chemotherapy for radiation failure. So this is the end of part 14, but let me remind you by the complication of or side effect of chemotherapy. So chemotherapy is most likely to cause many side effects. The urinary retention commonly occur 1 to 2 weeks after it is occur secondary to chemotherapy, but it resolves after 1 to 2 weeks and can managed by indwelling catheter and anti-inflammatory. Genital swelling, this is common. Genital swelling is common, but it's usually resolved 2 to 8 weeks. Benign parathesia, this is also common after aggressive anterior freezing, and it is usually resolved 2 to 4 months. Genital swelling, this is common, 2 to 8 weeks can be resolved. Erectile dysfunction, this can occur in 80 to 90% of the cases. Urethral sloughing, this is the less than or equal 15%. Urethral obstruction and urinary incontinence is very high when the patient have TUR or bladder neck resection. Therefore, it must be aggressive resection must be avoided. Rectal pain, 12%. The percentage near to urethral sloughing is less than or equal 15. Rectal pain, it's 12% of men after primary chemotherapy, but up to 40% after chemotherapy for radiation failure. Chemotherapy after radiotherapy, it's reached 40%, but primary chemotherapy, it's 12%. Urinary incontinence, long-term stress incontinence is usually mild and occurring up to 8% for men of primary chemotherapy and 22% for men receiving radiation and have a failure of radiation, and they're receiving chemotherapy, it is 22%. Those have urinary incontinence. Fistula. That the fistula, it might be urethrorectal or urethrocutaneous fistula, in occurring less than 1% for primary patient who receiving chemotherapy, or it's up to 10% in patient who receive radiation and then receiving chemotherapy due to failure of radiation. Okay, we'll meet again in another